Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine podcast. I'm your host, Yaron Ivan, as usual. And today I'd like to share with you a discussion I had with another PEM physician and another EM physician about pediatric emergency medicine. Why is it so special? And what advice we, PEM specialists, have for beginners, medical students, residents, or anybody who's just not comfortable taking care of children. This discussion was part of the ACOEP National Assembly, of which I had the pleasure to participate and give lectures in for several years now. It's a great honor and a great privilege. I hope you enjoyed the discussion and learned from it. You can also hear this episode and much more emergency medicine podcast on one of my favorite podcasts, EM Over Easy, the podcast that inspired me to start PEM Rules.
Hey, MedStudent Over Easy listeners. This is Patricia Capone, one of your co-hosts for our MedStudent Over Easy section. And today I am joined by two amazing guests that I'll have introduce themselves. And we are going to talk today about pediatrics.
So thank you very much, Patricia. I'm Yaron. I'm a pediatric emergency physician at Sunrise Children's Hospital in Las Vegas. I did my residency in general pediatrics, finishing in 2013. And fellowship in pediatric emergency medicine in 2016. I work with the residents and the fellows at Sunrise Children's Hospital in Vegas.
Hey, Patricia. I'm Delia Gold. I am an attending at Nationwide Children's in Columbus, Ohio. I did residency and fellowship there and graduated in 2014. And I hang out with all the learners because it's a huge teaching hospital and part of Ohio State University. That's what I'm doing here.
So I have the awesome pleasure of working with Delia actually at Nationwide. So one of the reasons that I wanted to bring you guys on was to talk a little bit about examining and kind of gaining history from pediatric patients from the lens of a med student. It can be really daunting sometimes to work with different age groups, especially if you don't have kids or you don't have nieces and nephews. What is your general approach, or I guess the general approach that you would give someone that's newly learning how to interact with the pediatric population in the ER?
So number one, it's a very, very good question. And I have to be honest, obviously different doctors, different opinion, but my approach to the pediatric patient, and I would never, ever discourage, God forbid, any medical student from doing a good physical exam. But I have to be honest and say that most of the time, especially in the newborn, the physical exam on a pediatric patient is, and I say it with a heavy heart, semi-useless. The kid is screaming, you can't hear the lungs, you can't feel the abdomen. So I think we all got to be honest. My approach, and it's one of the rules that I talk about in my podcast, PEM Rules, the way to become a good physician is to get a good story. So many times, I would want to say most of the time, if you sit down, with the parent, and get a good HPI, that will get you much further than the physical exam. With regards to the physical exam, though, I would say that I think, unlike in the adult world, it's really, really important to realize that your physical exam starts when you enter the door. So, respiratory distress, you can see that. Child with bronchiolitis who's struggling, you can see that. A child who is septic, which is few and far in between, you can see that. So my biggest advice would be to look at the child when you enter the room right away and start thinking about your physical exam.
Yeah, I would echo that observation is a huge part of doing your exam of a pediatric patient. So I remember distinctly being a medical student and I was on my peds rotation, and as all medical students, people want to get in and get their hands dirty and actually, put lines in and touch patients and sew in the OR. And I went to my peds rotation and I had heard that at this site that they were very clear that you were observing and you were shadowing. And a lot of people didn't like it. And I actually did not mind it at all because of exactly what Yaron's talking about, which is watching a child, especially when you're talking to their parent and they're distracted. You see a lot about what's going on. So the mom, the history matters, but sometimes the parents have a pretty strong opinion when they're talking to you. So I always listen to them, but if they're going on about like a patient being in excruciating pain, and then I'm watching when the kid doesn't know I'm watching and I see that they look comfortable, it doesn't mean I'm not going to work them up, but I definitely will put it in my back pocket And observation is definitely very important in pediatrics, especially when they're pre-verbal. And so I agree. I don't agree about the exam per se, but I agree that a lot of what you get in peds is through talking to the parents and watching the room and watching the child.
What are some of those questions that when you're gaining that history might be a little bit different that you may not necessarily ask of an adult patient that you would want to know from mom or dad for a young patient that maybe can't talk to you?
I ask a weird question of, are they smiling? Which I think is just like when EM people come to a peds ER and I go, are they smiling? They will at first look at me like I'm crazy, but like a young preverbal kid who can smile, that is a mental status check, so to speak. And so I will ask weird things about their behavior. We, depending, we're peds EM, so we don't go all super deep on like what kind of water and how many pets and long family histories. Like we really do try to keep it succinct, but we will ask more things about like dynamics, having to describe things to parents. So it's pretty weird, but I can like act out a lot of breathing trouble. I'm really good at croup. I don't want to get a acting gig based on this podcast, but like my stridor is pretty spot on. We love to pull our phones out, show poop, show like different pictures of rashes because it's just very different in peds. We have to take care of the kid, but we also have to take care of the parent. And half of the interaction is figuring out what the parent is worried about and what they want. So those are the things that I kind of keep in my back pocket that I just don't think are at play as much in regular emergency medicine. Maybe geriatrics, I think, or like when you have someone who has a caregiver, but kids are lucky. They have someone who generally cares about them no matter what, they might kind of seem like. They're there because they're worried and they have a concern. And so I think we all try to use that to our advantage to help figure out what's going on.
Yeah, and I agree with that. I think if I had to think of few things or two things that come to mind that are PEM specific with regards to history and physical exam is kind of my advice to students is to break off from examining head to toe or toe to head or anything like that. So very often, if I walk into a room for a child or newborn with a respiratory complaint, and I happen to walk in there and mom is holding the baby and the baby is quiet, my first thing is, Mom, I know why you're here. Your baby is very quiet now. Let me just take a listen and then we'll talk. Because I know that once we sit down and the baby sees me or some noise, there might be a lot of crying and then my physical exam is out the door. So again, I totally break the rule. I do my physical exam before the history, but at this moment, I think it's appropriate. The other tip that I give a lot of medical students is one of the red flags that makes me a little worried in children is the child who's truly nauseous. We talk about anorexia as being a very sensitive sign for appendicitis. And, asking a 3-year-old if he or she are nauseous is kind of difficult. One of the ways that I go about it is I look at the child and I ask, what's your favorite food? And sometimes, most of the time, I get, some junk food like chocolate cake or something like that. And then I look at them and I ask, if I gave you a chocolate cake right now, would you eat it? And I'm always very worried about the child who refuses imaginary chocolate cake. That makes me very worried that this child is truly nauseous, and that doesn't sit well with me. So that's one tip that I also give the med students about it.
Yeah, so I know, and I've actually started to change my practice a little bit with my adult patients is I would get into the habit of asking for pediatric patients, are they eating, are they drinking, peeing, pooping, all of that stuff. And I actually started asking my adult patients that because I was like, I learned so much just from those very few questions. But I think it's so right? We're so regimented in, okay, I have to take the history first and then do a physical exam. And sometimes, like you said, you start the physical exam as soon as you walk in the room and just by watching. So we talked a little bit about more younger children aren't able to really talk to you. How do you kind of break through with more of that like preteen adolescent population? Because I think sometimes we forget about them because they are still pediatric, but we often like jump to kids when we start talking about pediatrics.
We like kids and everything, but I mean, preteens are rough either in your home or in your hospital. So I would say that some of the things that help is just, again, it's observation. Like you can get a read on the maturity level of the kid, and that dictates a lot of at least my care because sometimes, just last night or 2 nights ago when I was working, a child by age only, but not by size or build, was hurt and seemed okay because I had kind of made some implicit assumptions based on his build. And I was like, okay, well, we're going to get you cleaned up and cleans your wounds. And he started to sound very teary and was like, well, it's going to sting. And this kid was literally off my bed in every direction. And I said, oh, I have to remind myself, who've done it many years, that he's 12. And he's just kind of a young 12. And the mom's like, yeah, he's a young 12. And so knowing where they're at in maturity level is a lot to do with observation, but it'll also help you know what to do with the complaint. You can also tell sometimes about if they give the history versus they have their parent give the history. And then the exam, I would say that we are more likely to separate the kids actually than maybe an adult trained person, because I think adult trained sometimes is like, oh, 16, 18. And I'm like, no, girl, 12. Like, I'll go even lower if I feel like there needs to be a separation to get kind of at how bad symptoms are or what's actually going on or how they feel. So I think we're at an advantage because we are around kids a lot. We observe kids a lot. But, even if you don't spend a lot of time around kids or you don't have kids, it's kind of just a more honest and direct, I feel, interaction without a lot of concern for nefariousness and like trickery, even in a preteen. Like they're not really, if they're doing something like that, it's because they're just being like a little immature or they're scared. It's not the same level of like, I'm going to give you a different story. I'm going to lie extensively. And they're bad liars. Let's just be real. Like they just don't have the years of practice that adults have. So I think treating them like kids is okay with regards to some of their pathophysiology, but the reality is they're right in between and you have to treat them a little different. And so those are some of the things I always remind myself and tell medical students and residents to do.
I agree with a lot of what you said. I think for us, PEM doctors, and, even when I say it, I kind of feel strange about it, but after, having so many patients who can't really communicate with you and just talking to parents, it's kind of nice to see an adolescent and have one-on-one conversation. I try to relate to them. I think it's easier for me to relate to them because I have 3 teenagers at home. I got to be honest, this may sound weird. I bring my guitar for each and every shift. And when I walk in with my guitar and there's a teenager that looks like me when I was 16 with the long hair and the ripped chins, he immediately looks at me like, oh my God, the doctor knows how to play the guitar. And then we bond immediately and everything is pretty easy from there. But that's just something that I do. I think with the adolescents, I find that really treating them like adults or sitting down, kicking mom or dad out of the room and having one-on-one conversation while, you really look like you listen and you listen goes a very long way.
So you both talked about separating parents and the child. How do you go about that? What do you kind of say to parents? Do you have a script or like something that you've adopted that usually lands?
Yeah, that's a good question. And honestly, more and more in this country, with some of the kind of political stuff going on, you have to be careful how you phrase it and your reason, because people can assume that you're going to be asking all these crazy questions. And it might just be that they were the ones who knew the story and I felt like the mom was interrupting them. So it's not even anything about, oh, I think you're up to some fun, crazy things. I just want you to talk. So I would say that it depends on the complaint, as even if I separate them. Because if it's not something, if it's like a cold, rarely does that like play out. If it's altered mental status, oh yeah, mom's got to go. Or even if mom like thinks that she's so cool and into it and like she knows, I still kick them out. I think we could go on a long laundry list of what you would kick a parent out for. But I think the chief complaint sets it, the dynamic, how it feels in the room. And I'm really polite. I just say, hey, they're getting older. Like how, Yaron was saying, they're basically pushing that they're getting to be an adult and they're going to be driving soon, various things like that. Whatever I think I need to say to help the parent understand it's not about them, it's that I'm like honoring their child and the stage in life that they're in. And I just want to give them a chance. If you tie it also to the GU exam, that also is, then they don't really question why you're kicking them out because they know that young man doesn't want his mom in the room. And then I might do the exam because they're real nervous. They want to get it over with. But then I'm like, hey, is everything else okay? Did that sound right? What your mom said? Is there anything else you want to tell me? So you just time it up and you read the room. And then obviously, as with anything, if the parents are going to push back or there's any kind of perceived issues, you just have to deal with it as it comes and try to get them to understand that you're just trying to help the child. And it's not like you're trying to like get a report to children's services or various things that like people's brains can go pretty dark. And I try to just establish a good rapport from the beginning so they don't, their brain doesn't go there. And then usually I don't have any problem with getting the parents out.
Yeah, I don't know if I've been just been lucky or what.
It's the guitar, I think.
I think
it's the guitar.
I don't think in my history as a physician since finishing fellowship, I think I've had one or two parents who gave me a hard time not wanting to leave. So, usually I just look at the mom or the dad and I'm like, Mom and Dad, do you mind if I speak to him alone for just 1 second? And I don't think historically I've gotten any pushback again, maybe once or twice. I don't even remember what I did, but I just explained to the parents that, it's the nature of the beast that your child is now 17 and he's allowed to have some privacy with regards to certain issues. I don't think I've ever had significant problems there.
I think just being like honest, clear about it and just being straightforward.
And usually when there's a problem, it's got very little to do with us. It's more to do with a prior experience they had, maybe with another child or with various just things in their life that there's some trust things. And so it doesn't happen a lot, but I do find if you don't have the awareness when it does happen and you show your surprise as opposed to like understanding and trying to get to a compromise, sometimes you can lose some of the therapeutic relationship.
If there's one thing or one or two things that you can think of things that you've seen students or residents do where it kind of like, you were like, ooh, maybe we're not going to do that next time, or that was a little cringeworthy, what would it be?
So the one thing that popped in my head, this is not like the most common thing or the everyday thing, but as we've talked about, peds people are very observant. Like we hear stories all the time. So when you are telling your story to us, when you are staffing, just know that we can kind of tell when you're fibbing or like fluffing or you didn't really ask. That's my favorite. And it's all the way up, even to fellows until they get to know me, that I will sniff it out and I'll be like, I'll say, what about this? And they go, yeah, they're not complaining of that. And I'm like, they're not complaining. And then I go, did you ask? And then they go, I did not ask. And so I would just say that you're going to get asked weird questions by peds trained people because we're really observant. We listen very closely to histories. That is our main thing in our pocket. And so as much as it seems anal to you, we're going to drive, as Yaron said, we're going to drive like 90% of what we're doing based on the story. So it needs to be accurate. So that would be my thing.
Yeah, I think where I've seen mostly ED residents as opposed to the pediatric or family medicine residents not failed, but maybe do things that I would like them to do differently is I think the emergency medicine residents are always very focused on volume. So, in the emergency room with your adult patients, and I know because part of our fellowship, we had to see adults, you go into the room and you rely heavily on your labs that were maybe ordered before the patient even walked out, or the CT that you're almost definitely going to order because the 50-year-old has abdominal pain. But in pediatrics, we don't do that. So sitting down, getting a good story, and paying attention again to spending more time with the patient as opposed to seeing a lot of patients. So my battle oftentimes with the emergency medicine residents is they go very fast, and sometimes they compromise the HPI and they just walk out. And they expect me to agree to their CBC, CMP, CT with every patient, which I'm not going to do. I much prefer that they slow down, get a better HPI, get a better story, and maybe we don't need to do that CT. With the pediatric residents, I feel like it's oftentimes the opposite. They spend a lot of time with the patient and maybe not fail.
I mean, how many cats? Is it a tabby? Is it a calico?
Is the diaper this?
Is there Siamese in their family? I mean, it can go deep. And occasionally it matters, but he's smirking and he knows it. He agrees with me. It's not always, it doesn't matter if they have Siamese cats in their family.
But I think you both bring up a really good point of whether you're asking too many questions or not enough questions. Like if you didn't ask the question and the attending asks you, did you ask the question or not? If you didn't ask, say you didn't ask. Because like you said, the attending's going to sniff it out.
And I think it's even higher in kids than adults because there's just way more to ask. And you're asking two stories potentially, like the person living it and then the person watching it with weird complaints like, oh, they're walking funny. I mean, a kid can't tell you why they're walking funny. You have to watch them, but you also have to ask all these other people, what do you mean funny? What does that mean? And it's kind of tedious, I think, for EM trained people or adult trained, because you don't really ask those kind of questions, but it's the only way to get to it because the kid might not be doing it right then.
Well, Delia, Yaron, thank you so much. I think this was super helpful for all of our medical student listeners and early junior learners on how to really focus on, things a little bit differently maybe than they would for their, early EM auditions with mostly their adult patients. So I appreciate it so much. Thanks, guys.
And that is it for today, guys. Thank you for listening to PEM Rules. I hope you enjoyed and learned from the discussion about pediatric emergency medicine, which is clearly the best field in medicine ever. Obviously, I'm biased, but that is just my opinion. Thank you for listening to PEM Rules. Thank you for checking my column on EP Monthly and checking the Facebook page. I really enjoy all the discussions and all the communications. Please feel free to continue in contacting me. And if there's any topic you want to hear or any discussion you want to have that is in any way related to pediatric emergency medicine, I'm happy to have you on the show. Again, thank you for the support and see you next time. Have a great day.